Delirium is a disturbance of consciousness with impaired attention and disorganized thinking or perceptual disturbance that develops acutely, has a fluctuating course, and with evidence that there is an underlying physiological or medical condition causing the disorder. Background and significance of delirium. Delirium is often noticed in inpatient settings, however, may occur initially outpatient. Medical inpatients prevalence is 10% to 31%. Incidence is 3% to 29%. Mechanically ventilated patients in ICU are up to 83% during the ICU stay. More than 50% of medical ICU patients still have delirium when transferred to other units within the hospital. Risk factors for delirium are predisposing age, 70 years or older, severity of illness and cognitive impairment, also depression, sensory impairment, fluid and electrolyte disturbances, and polypharmacy, especially psychotropics. Precipitating central nervous system pathology such as stroke, metabolic, electrolyte, and/or endocrine disturbances, infection and drug toxicity or withdrawal, also pain, hypoperfusion, hypoxia, a number of drugs, like stated before, especially psychotropic and anticholinergics, and restraints. Environmental factors such as ICU admission, multiple room changes, and an absence of a clock or glasses. The significance to nursing practice. Nursing plays a large role in the management of patients with delirium. As bedside nurses, one must help provide environment and physical interventions. As an advanced practice nurse, it is important that one determines the cause for delirium and corrects it as quickly as possible. It is important that the nursing profession can identify the signs and symptoms of delirium. Impairment of consciousness, appearance and behavior, mood, speech, perception, cognition, orientation, concentration, memory, and insight are all signs and symptoms of delirium. Addressing the underlying cause, maintaining behavioral control, preventing complications, and supporting functional needs are all essential in the management of a patient with delirium. Subjective data of the patient consists of patient having no known allergies. Patient is currently taking metformin 500 mg BID for type 2 diabetes mellitus, Trulicity 1.5 mg weekly for type 2 diabetes mellitus, levothyroxine 100 micrograms daily for thyroid disease, losartan hydrochlorothiazide 50-12.5 mg daily for essential hypertension, metoprolol tartrate 50 mg BID for essential hypertension, amlodipine 5 mg daily for essential hypertension. Patient is up to date on pneumonia, influenza, and shingles vaccines. She has had her yearly eye exam, her yearly physical, pap smear, mammogram, DEXA scan, and colonoscopy, which all had normal findings. Patient is currently being treated for essential hypertension, type 2 diabetes mellitus, and hypothyroidism. Patient states that she went through menopause between the ages of 48 and 52. Patient states that she was hospitalized in 2009 when she had her gallbladder removed. She states that her gallbladder ruptured and that she was kept 2 days after the procedure for intravenous antibiotics. Patient states that she currently lives in a house with her husband. Delirium patient presentation and complaints. Appearance and behavior of a patient with delirium may consist of the patient looking unwell, and behavior may be marked by agitation or hypoactivity, by fluctuation between these states, or by a mixture of them. The moods consist of frequently labile with perplexity, intermittent periods of anxiety or depression, or occasionally of other mood states such as elation or irritability. Usually the mood states have an empty and transitory quality. The patient may mumble and be incoherent. There are abnormalities in all areas of the cognitive function. Memory, registration, retention, and recall are all affected. Mild cases may show their most pronounced abnormalities in slow performance on task or in wandering of attention away from the task at hand. Orientation in obvious cases would be person, place, time will be disturbed. Concentration is impaired. Insight is usually impaired. The patient will have no understanding of why psychiatric assessment has been requested. Pertinent review of systems. Patient denies fever or chills. Patient does complain of fatigue. Patient does complain of nasal congestion and mild sore throat. Patient denies any chest pain or palpitations. Patient denies any dizziness or fainting. Patient denies any swelling. Patient states that she does have a history of high blood pressure, but stays within normal limits with blood pressure medicine. Patient does complain of an increased shortness of breath with productive cough. Patient does complain of exercise intolerance due to shortness of breath. Patient does complain of productive cough with green sputum. Patient states that she has a history of type 2 diabetes mellitus, which is well controlled with medication. Patient denies heat or cold intolerance, polyuria, polydipsia, or excessive thirst. Patient does complain of a mild headache with congestions. Objective data of the patient consists of vital signs. Patient is 5 foot 4 inches tall, weighs 148 pounds with a BMI of 25.4. Patient's blood pressure is 128/82, heart rate of 94, respiratory rate of 21, temperature of 98.4, and oxygen saturation of 96% on room air. The physical exam, the patient appears to be dressed appropriately for the season, well groomed, good hygiene, no obvious signs of distress noted. Patient was ambulatory into the office without the aid of an assistive device. Patient appears to be stated age. Patient is alert and oriented and in no noted distress. Upon transillumination of frontal and maxillary sinuses, no illumination was present. Symmetric chest shape with no visible deformities. AP diameter is less than transverse diameter. No use of accessory muscles or retractions noted. Patient does complain of mild tenderness upon palpation of the chest. Patient's respirations appear to be unlabored. No masses or pulsations noted upon palpation of the chest or back. Breath sounds are wheezy bilaterally, anteriorly, and posteriorly. Right lower lobe demonstrates dullness upon percussion. Tactile fremitus is noted. Mini mental status exam 30, no cognitive impairment noted. Short-term and long-term recall intact. Perceptual ability, judgment, and reasoning intact. Decision-making capacity intact. Patient is alert and oriented. Patient is pleasant and cooperative throughout the entire exam. Geriatric depression score of 1. Patient states that she does not feel full of energy. A score of 1 is not indicative of depression. Screening tools that were used consisted of geriatric depression scale with a score of 1, which is not indicative of depression, mini mental status examination with a score of 29, which is not suggestive of cognitive impairment, home safety assessment checklist with a score of patient's home appearing to be safe and suitable, the simple frail questionnaire screening tool with a score of 0, which is not indicative of frailty. Patient has been followed by a current nurse practitioner for the past 7 years. Patient has been seen every 6 months for the last year. Patient had a normal CBC, CMP, TSH, EKG, and hemoglobin A1C in February when seen for annual physical. Patient will have CBC, CMP, and chest X-ray conducted today to assess for infection and electrolyte values. If this patient were to present with delirium, it is assumed it would be caused by infection. The onset of delirium would be rapid and the patient would present with the symptoms stated previously. It is essential to treat the underlying cause of delirium while maintaining the safety of the patient. It is important to educate family that delirium is temporary and should reside as the infection is cured. If the patient has been treated for pneumonia already and her infection is getting worse along with delirium, inpatient treatment may be necessary. Differential diagnoses for delirium include sundowning, focal syndromes, non-conclusive status epilepticus, dementia, primary psychiatric illnesses. Each diagnosis would be ruled out by determining the source of the confusion, how quickly the confusion started, and determining how long the confusion had been going on. Final diagnosis of the patient presented consisted of acute sinusitis, unspecified, wheezing, and bacterial pneumonia. Justification is the patient stated that she thought she had had a cold for the past 2 weeks, however symptoms continued to worsen and had progressed. She states that her symptoms have progressed into her chest as she is having shortness of breath with exertion. She also states that she does have a productive cough. Upon assessment, she has wheezing in bilateral lungs. Right lower lung demonstrates dullness and tactile phragmitis is present. The patient's condition likely started as a bacterial sinus infection and without treatment has progressed to bacterial pneumonia. The differential diagnosis can be ruled out due to the likelihood that the infection is bacterial instead of viral. It is not likely that the patient has a pulmonary embolism as she denies any chest or back pain and denies any blood in her sputum. It may be challenging for the family to care for a patient with delirium at home. It may be necessary for the patient to receive inpatient treatment regardless of the effectiveness of outpatient therapy. It may also be challenging for the patient with delirium to take outpatient therapy. The patient with pneumonia may need equipment such as nebulizers or inhalers. These can be well managed by primary care, however, pulmonary is a great option when needed. The patient may also need a pulmonary rehab consult to determine if supplemental oxygen is needed while sick. The patient with delirium caused by pneumonia in the outpatient setting may require a home health consult. The home health team will help ensure that the patient has a safe environment at home while ensuring that treatment is being completed. A psychiatric consult may also be helpful in the management of a patient with delirium. The patient did not demonstrate any health behaviors that would indicate delirium. However, delirium can be a complication of pneumonia. The patient was assessed for any economic, political, or psychosocial factors. The patient assured staff that she would be able to afford the medication being prescribed to treat her bacterial infection. The patient denied any political factors that would affect her care at this time. The patient denied any psychosocial needs at this time. The patient seemed satisfied with the plan of care being delivered. When caring for a patient with delirium, there can be legal aspects that can affect the patient's care. It is important to determine if the patient is of sound mind and judgment when you are determining their treatment options. A patient who is not of sound mind and judgment may not be able to refuse medical treatment. However, a patient with delirium may try to refuse medications. It is important to communicate with the patient's family and make sure that they are in agreement with the provider's plan when a patient is not of sound mind and judgment. Throughout my research, I learned what the true meaning of delirium was. It is often confused with other disorders that affect a patient's memory. Delirium differs from most of these disorders by its quick onset and its short duration. It was helpful learning what the roles of a nurse is in the care of a patient with delirium compared to the roles of an advanced care provider. The prevalence of delirium was much more than I expected during an inpatient stay. Effective management of delirium includes finding the cause and treating it while maintaining the patient's safety and integrity.